Hi, this is Alicia Bright. We were going to discuss medications that are used when we're trying to maintain glucose balance. So self-monitoring of blood sugar is key to successful management of diabetes, and of course we do it on the units all the time in the hospitals to assess where our patients' blood sugars are at, no matter what their issue is. They may be on TPN, total parenteral nutrition, or they may have pancreatitis, or they usually are diabetic. So sticking fingers is one way to do this. We also have continuous glucose monitoring machines, and these, you can see the machine is, there's a little probe under the skin, which is connected to a monitor, which can alarm if the patient's blood sugar is going too low or too high. And at any rate, you can set where you want it to be, and you can read out trends over time. This is information that's really valuable for someone who's trying to have tight control over their diabetes. It also provides feedback for the physician who's managing the patient. These are great if you can use them, but if you're really active physically, it's not necessarily appropriate. So not everybody can use them, but it's a lot of data there for the patient who really is trying to manage blood sugars intensively. So we talked about carbohydrate counting. So there's two classifications basically of medications for diabetes. One is insulin, and the other are oral hypoglycemic agents. So carbohydrate counting is one way to utilize insulin to manage blood sugar, and we talked about that when we talked about diabetes. This is where you have you figure out how much carbohydrate intake you're going to eat in the next meal, and you add what you would take for the sliding scale, and you take that shot while the meal is hot. There's also sliding scale insulin. The problem, this is more common because you don't have to calculate carbohydrate dosage, but it's less effective because basically you're trying to get blood sugars down to where you want them based on how they are before you eat. But of course, as soon as you eat, those blood sugars are going to go up. So this does not result in control that's as tight as carbohydrate counting, but it is a little simpler for people who have trouble managing carb counting. Oral antihyperglycemic agents or hypoglycemic agents, these are pills. Insulin is not administered by mouth. It doesn't survive the stomach, but the pills that people can take for type 2 diabetes are orally administered and a lot less painful to take. We'll talk about this classification. So this is a chart of normal insulin secretion. Typically during the day, somebody who's eating breakfast, you eat breakfast, and after that your body metabolizes the food, takes it into your system, and that will naturally raise blood sugars. Well, the body will naturally raise insulin levels to keep those blood sugar levels from going too high and to move the blood sugar from floating around in the blood into the cells where it can be useful. And as you can see, if somebody ate 3 meals during a day, we would expect the insulin levels to rise after the meal each day. This is what we're trying to accomplish with preprandial insulin injection. This is a chart that shows the onset, peak, and duration of commercially available insulin. So basically there's 4 kinds: rapid acting, short acting, intermediate acting, and long acting. The rapid acting is known as Humalog, Novolog, or Apidra. The onset is 10 to 30 minutes. It peaks at 30 minutes to 3 hours, and it lasts about 3 to 5 hours, excuse me. The short-acting insulin, regular insulin, Humulin R or Novulin R, the onset is 30 minutes to an hour. It peaks 2 to 5 hours, and it lasts 5 to 8 hours. Intermediate acting NPH, Humulin N or Novulin N. The onset is 1.5 to 4 hours. It peaks in 4 to 12 hours, and the duration is 12 to 18 hours. Long-acting insulin like Glargine or Lantus and Demeter or Levemir. The onset is 0.8 to 4 hours. There's no real peak. This is a long, slow-released insulin. You should be familiar with these, with the length, the duration of action of these insulins and the names of the different kinds of insulin. We would use typically rapid acting or short acting to cover the carbohydrate you're taking in a meal. We would use intermediate acting to give a longer coverage, and we use the long acting typically to provide a background basal rate of insulin in the body. You don't want you don't want the insulin levels in the body ever to drop to zero or very, very low, because then it just has an effect on blood sugars where they start to get out of control, and it's hard to balance. Blood sugars will go really high and then really low. So if you have a small amount of background level of insulin, the patient's going to be more stable. So that's why they'll sometimes administer the Glargine first thing in the morning, so they have a little 24-hour coverage of insulin in the body. Just as a review, insulin syringes are for insulin and only for insulin, and you only ever administer insulin in an insulin syringe. They are flagged orange for a reason. And there's different sizes. They range from syringes that are marked, that are 0.3 milliliters and marked with half unit markings. You can get very, very precise doses of insulin there. Through 0.3 milliliters that are marked with full unit, through 0.5 milliliters, 0.5 milliliter, goes up to 50 units, and then a 100-unit syringe of 1 milliliter. Remember, when we're talking about units of insulin, that's the measurement specifically for insulin. General principle is you want to use the syringe that's going to give you the most precise way to measure the dose of insulin. Just as a review, insulin gets injected into the soft, fatty areas of the body. So the backs of the arms, the hips, the belly, the thighs, anywhere where there's extra fat on the body. We don't want to inject insulin into a muscle. We have insulin pumps as well. These have been around for, I think, about 15, almost 20 years now. Again, they're not for everyone. For instance, my little brother, who's in his 50s with type 1 diabetic since he was 7, he's very active. He works out and does martial arts. And so he does sparring, and this kind of get-up would not work for him. People who swim, they'd have to take this on and off all the time. So it works well for people who aren't that physically active. You can exercise with it, but the more vigorous your activity is, the less well this is going to work for you. Again, the needle rests under the skin. It's attached to a remote, and the person can just self-administer a dose of insulin just by pushing a button. Very convenient. All right, so what goes down might need to come up again. If blood sugar goes too low, we administer glucose gels or tablets. Those are carefully calibrated to contain 15 grams of carbohydrate. We have glucagon injections. Remember, glucagon is the hormone in the liver that raises blood sugar levels, and we can administer that. We also have IV glucose. So if someone's blood sugar is really low, we might just give them an IV glucose, especially if they're unconscious. If they're unconscious, we don't want to put anything in their mouth. They might choke. So we just have to get an IV going, give them some glucose. And that's actually on the protocol for an unconscious patient. If EMS is, paramedics find somebody who's down on the road, a lot of times that's a narcotic overdose, but if the Narcan's not working, giving them an AMP of D50 would rule out having it be a hypoglycemic episode. If their blood sugar is low, it'll save their life. If their blood sugar is normal or high, it's not going to hurt them. But if it's low, that might save their life. I just want to remind you about the rule of 15. So that's the rule of 15, where you check a blood sugar. If it's low, you eat 15 grams of carbohydrate. You wait 15 minutes, and then you check blood sugar again. And that's to allow the carbohydrate time to get into your system. All right, so insulin has to be injected. We use insulin for type 1 diabetics. Sometimes we use insulin for type 2 diabetics also. However, type 2 diabetics are typically started out on metformin. That's the first line drug. Now, remember, type 2 diabetics may be able to get their blood sugars under control in the early stages of the disease by losing weight and exercising, but not always. So it's important to be supportive of our patients and educate them about their options. But, not everybody's going to be able to manage it that way. And so, medications are a good option to have also. So metformin is the frontline drug. This decreases production of glucose by the liver. It increases intestinal absorption, it decreases intestinal absorption of glucose so that you don't absorb as much sugar to begin with. And it slows the uptake of glucose by tissues. What it doesn't do is increase insulin secretion from the pancreas. So it's not going to create hypoglycemia by stimulating the pancreas to make more insulin. Therefore, it's a safer drug than all the other diabetic medications. Sulfonylureas include diabanase and tolinase, amylyl, glucotrol, glyburide, diabeta, micronase. You've probably seen some of these medications already in your units. These medications do stimulate insulin secretion from the beta cells of the pancreas, so they do increase insulin levels. Therefore, beta cell function has to be present, which means basically it doesn't work in a type 1 diabetic. They don't have the beta cell function. It does work in a type 2 diabetic, usually. Sulfonylureas improve sensitivity to insulin in tissues, so they decrease the resistance to insulin, lowering blood sugars. These are not as common as they used to be, but they're still frequently used. The glinides are similar to sulfonylureas, but they are a shorter duration, so they're actually safer. If you think about it, if somebody gets into trouble and the medication continues, the effect continues for a long time and their blood sugar is already low or they're not eating, you're going to be worried about them a lot longer than you would be if the drug lasted less time in the system. Prandin and Starlix are examples of glinides. And then the glitazones regulate the genes that are involved in glucose and lipid metabolism and increase insulin sensitivity. Actose and Avandia are examples of these. And I just want to point out that these medications are used if other medications don't work for patients. Avandia actually, shortly after it went on the market, they started having a lot of diabetics dying from the medication, and I think it was liver failure. And they banned it in the UK. They brought it back here in the United States, but it's supposed to be used with great caution because it does have some pretty lethal side effects. Alpha-glucosidase inhibitors, Precose and Glycet, actually block an enzyme that breaks down the sugars in the intestine. So in other words, you can eat that ice cream sundae, but it ain't going to get into your system. And actually, they're kind of antisocial drugs. They can cause a lot of gas, diarrhea, belly pain, and they can damage the liver. So again, some of these medications, they'll add to a regimen that includes metformin, sulfonylureas. If that's not doing it for the patient, they might add some other drugs as well or change them. There are also some medications that are new on the market, injectable medications that last a little bit longer. Maybe you have an injection every couple of weeks. I don't know how widespread those are at this point, and I can tell you that in the hospital, they prefer to manage all diabetics with insulin. They take them off the PO meds and just manage their blood sugars aggressively with insulin. That's the preference because we have tighter control over it, and giving somebody a medication that lasts for 2 weeks in the hospital, it just makes it a little more complicated to manage the patient. So that's what you're going to see in the acute care environment. All right, let's remember that the foundation of good care, good blood sugar management is good nutrition and exercise, and staying away from the junk food. All right, thanks. Hope that's helpful.